live. And I'm going to omit everyone her name. Is that okay?
Right. Okay.
So everyone's arriving.
Okay. Hello, everyone. Thank you all for coming. So welcome to the next sort of series in the Virtual IR Journal Club series. Thank you all for making time of your day. We have great host panelists. And what we're going to be looking at is iliac vein obstruction. And specifically, we're going to be looking at Venogram versus IVUS and how they've tackled this in the video trial. So this is all going to be recorded. This is all going to be online. And what we'll do, we'll just get into it. We'll give a bit of a background about Venogram, venography, IVUS, and the video trial, and then we'll go to our panelists and we'll just have a discussion on some of the points raised. So hope you guys enjoy this. So just to give a background, I'm a radiology registrar based in London at the moment. We have Ben Thompson, who's another registrar based in London. We have Dr. Kumar Dasari from Chicago, Rush University, Dr. Narayanan from King's and Guy's and St. Thomas's in London. And we have Dr. Chris Hammond, who unfortunately is busy on call. So if he gets a chance to make it, we'll see him then. But he might not unfortunately be able to make it. So without further ado, what we'll do, we'll get started. So Venogram versus IVUS for diagnosing iliac vein obstruction, or the video trial. The paper we've sort of sent out before, and if anyone's had a read of it. If not, don't worry, we'll go through some of the salient points of the paper, and we'll go through what issues might have been raised. We've got a bit of a wide variety of an audience. We do have some medical students, so just to give a bit of a background, there's a wide variety of ILIOFEMORAL venous disease. You have venous stenosis, you have extrinsic venous compression, such as May-Thurner syndrome, you have consequences of sequelae from deep vein thrombosis, and you have post-thrombotic syndromes. And these are all diseases that can result in ILIOFEMORAL disease that might need treatment from an interventional radiologist. Now, what's the issue with angiography in venous disease? They're not quite like arteries. They don't have that muscular wall. They're quite elliptical, which makes it quite difficult to quantify the degree of stenosis, percentage of stenosis. The size of the vessel usually changes depending on how dry or hydrated they are, and it changes with respiratory variation, and its shape and volume does change. So assessing it with angiography, it's a very dynamic structure and makes it complicated to assess on one single view. So you use multiple views. Where IVUS comes in is it's a great modality for assessing the entire structure of the vein. You can see the musculature wall, you can see different pathologies, you can see plaques and calcifications, you can see you can see it in real time. So you don't have to rely on a 2D image. You can see the patient as they breathe in and out. You can see how the shape of the vein changes. How it's able to assess certain vascular characteristics. Angiography is good. And it's a dynamic modality, so you can see flow through a vessel, but for everything such as stenosis, plaque, thrombus, and how well a stent is posing, the IVUS is where it really comes into play. And so it has excellent characteristics, and usually these are used together. You don't use one by itself, you use both of them together. In terms of the role of IVUS, you're able to see thrombus that's it's non-occlusive. You're able to distinguish chronic versus acute thrombus. It also gives you the ability to see sort of luminal features that you can't really assess with venography. You can see trabeculations and issues with valves in particular. And when it comes to deploying stents, you can see the landing zones of the healthy vessel wall. There is also increased accuracy in determining luminal stenosis, and I've highlighted this in red because it's an issue we're going to discuss in the trial. And theoretically, this is a well-suited modality for assessing venous disease. So how does IVUS compare to venography? Which one has the better assessment of the vessel? This is why I think the video trial came into play. And so this was a study published back in 2017 with Paul Gagné and his group in Pennsylvania. You have a 14-month period from July 2014. So The way this was done was it was a prospective, multi-center international cohort study from July 2014 to 2015, included patients undergoing IVC, iliac, and femoral venography, and these were lesions with intent to treat. So the classification system they use is the CEAP classification, and if you can see here, C4 to C5 and C6. So these are all legs that have disease. This is not just, a bit of edema. This is not varicose veins. This is true, they have, wounds, non-healing wounds, pigmentation, eczema. So these are true symptomatic patients. In this study, they excluded patients who had previous stenting or surgical bypass, or patients who were acutely having a DVT. And so this is one more strengths of the study is only included symptomatic patients, so patients in which, using, IVUS and changing treatment actually would make a difference. The way they planned the study was they got 100 patients. They did the venogram first, recorded the treatment decision based on the venogram alone, and they took 3 views of the vessel. After making the decision, recording the treatment decision venogram, they performed IVUS, and then they made a decision based on the venogram and IVUS. The intention to treat, they treated based on the physician's results. If they felt that the lesion needed to be treated, they would perform the treatment. If not, they wouldn't proceed. And what they did was try to record whether or not performing IVUS actually changed management. So again, they performed the venogram first. They had 3 views. They measured the luminal diameter. They measured the diameter of the normal lumen and of the area of stenosis. And the treatment decision was based on the percentage of stenosis. What they did quite interestingly in this paper as well was they sent it to a third lab and calculated the percentage area of stenosis from these 3 views. Again, this is another question that I found quite controversial, and we'll discuss later on. After performing the venogram, they assessed the vessel with IVUS, and what they did was measure the luminal diameter of a normal vessel and the area, and the diameter of the diseased area and the area at the area of stenosis. Again, one of the strengths of the paper that we found was, you have a third-party core lab measuring all these. So it's not, at the time, the decision to treat was based on the physician treating at the time, but you have a third lab that actually is able to compare how valid are these measurements, how accurate were the measurements performed by clinician at the time. And again, this area of, calculating area from 2D venograms, how valid is this? We'll discuss. So with 100 patients, 100 legs treated, the study found that venography underestimated diameter reduction by 11% compared with IVUS, and this was statistically significant. 26 patients with significant lesions, and the way they calculated significant lesions was more than 50% area reduction. And 26 of these subjects with significant lesions of IVUS had non-significant lesions on venography. Again, 50% area, this is another area that we're going to discuss when it comes to our discussion. 32 subjects, IVUS detected a significant lesion, and whereas venography failed to detect a significant lesion also. You can see that IVUS is a lot more sensitive for detecting lesions and is able to show a higher percentage of stenosis. The other features of IVUS, as we described before, it's not just looking at a 2D structure. You're not just seeing flow through a vessel. You're able to see different characteristics of the vessel. So you're able to see venous scar, which venography is very poor at doing, or venous spurs. Another great use of IVUS is respiratory variability. Again, this is something they didn't really discuss in the paper, and how it does change management. Now, this is an area where they try to compare the area calculated by IVUS with the area calculated by the venogram, and you can see that the correlation is pretty poor. They haven't provided an R value for this, which they'll provide in the next slide, but you can see that there is a slope and there is a trend, but it's not a straight line. And there's a lot of variation between both the area calculated by both modalities and the diameter. The Bland-Altman plot that they use and the way they correlated the two measurements was intraclass correlation. You can find that actually is fairly low. It's 0.50, which is a low level of concordance. But it favors increased sensitivity IVUS. So IVUS is able to detect more areas of stenosis and a greater degree of stenosis. An issue that we had with this paper is the decision to make the treat lesion was based on operator's preference and discretion. So it wasn't based on a statistical cutoff of 50% stenosis. But the concept of 50% stenosis was being agreed as significant is an interesting issue, because this is determining 50% in one modality as similar to 50% in another modality. How valid is this? We're not really sure. But when they actually treated these patients, 50% stenosis was not the sole criterion to determine treatment. It was based on how the physician felt at the time. As we said, IVUS detects more significant stenosis based on cutoffs, but is this truly increased sensitivity? And how relevant is this for outcomes? So the overall sense of the paper, it was multi-center and prospective. They had a third-party co-laboratory to analyze the results, and only symptomatic patients were included. But there are several questions raised in how do we decide a 50% cutoff, and is this justifiable? Is comparing measurements between imaging modalities ever justifiable? I mean, we struggle with abdominal aortic aneurysms and ultrasound and CT, comparing the two. I mean, how can you go, that, and that's a solid artery. How do we justify this in sort of a vein that's very, it's a very mobile structure? Again, we can never do these studies without industry support, but there is a little bit of conflict of interest. One of the authors is a speaker for Philips Volcano, and how does this play into interpreting the results? Whether this actually improves quality of life for the better, determining whether this is a more treatable lesion, treating more lesions, does this actually change outcomes? Large stent diameters were used in the trial, and there's also a question about whether they're over-treating with IVUS. So we thought this was a good paper. IVUS is a great modality, and we'd never use the two separately. But there's a few claims in the paper that we felt, there are questions to be answered, and we, is this paper valid in determining, 50% cutoff, and does IVUS have a bigger role to play than just determining a high percentage of cutoff? So that's our presentation. And what I'll do, I'll pass it to Ben and the other co-panelists. And Ben, I think we raised some areas of discussion. We thought we'd just share Dr. Narayan's thoughts, Dr. Kumar Madashri's thought, and Chris Hammond if he's around.
Well, that's great. Thanks very much for that presentation, Ian. That's great. Can I just say to everyone who's watching, if you have any questions at all, just use the chat function at the bottom tab, just to any questions you want to ask to put to the panel as well as we go along. So probably the first question to ask the panelists, I guess, is just the overall structure of the trial. As we know, venous disease has moved forward quite a lot in a short space of time. Do you think the kind of questions it asks are kind of relevant to your practice today? Because it's basically asking, is venography or is IVUS superior to venography? But in your practice, I would imagine most of you are using IVUS. And do you think it sort of tells us anything kind of relevant so does it sort of take your practice any further forward in that sense? Question for Narayan first, if that's all right.
Hi, great talk, Nane, thanks. So, I mean, to be slightly provocative here, I would say that if you're doing deep venous work these days without IVUS, that's borderline negligent. So there, there's my opinion on using IVUS for venous disease. But having said that, these trials take a long time to design, recruit, and come to fruition. And even though the results came out, by the time the results came out, pretty much everyone decided that who does deep venous work seriously will be using IVUS. It was kind of a foregone conclusion. At the time when the trial was conceived, that wasn't necessarily the case, right? There were a lot of people who were doing deep venous work relying solely on venography, maybe even just single planar venography. So I think it was, even though the results don't come as a surprise to those of us who use IVUS regularly, it was a trial that kind of had to be done to demonstrate to those who didn't use IVUS in their practice how much information they were missing out on by using it. Yeah.
That's great. And Dr. Madaseri, do you have any sort of similar views to that?
Yeah, first of all, thank you for allowing me to be on here. I appreciate this. It's a great discussion. Full disclosure, I do one of my consultancies with Philips, but that being said, I don't use IVUS on every single case. I think it's a great adjunctive tool. I think it's something that definitely for academic purposes and for difficult cases gives you a lot more information as to when you want to get more objective information in there. That being said, you know, especially depending on how you train and where you're trained and your experience with venography in general, I think the good point here is that they use multiple projections in DSA venography, which many people don't consider. When you're interventional radiologists like the group we're talking with here, we have a lot more comfort level with imaging-based evaluations, stenosis, looking for the secondary, tertiary signs, pressure measurements. IVUS does gives you a lot more detailed information, but I think we've seen that even with IVUS, we've seen a lot of issues with people not utilizing it appropriately, missizing still. I don't know how it is in for you guys over the water, but we've had some stents recalled recently that were venous design that were for migration and other issues, which shouldn't be happening with the operators using IVUS. So I think it's a great adjunctive tool. I think the study doesn't answer the question in my mind. You'd have to prove it to a lot of people to say this is something you absolutely need. I think you'd have to see outcomes on those who are randomized to doing it or not doing it. And I think that's just where I personally sit with it. I do think it's a great tool. I teach our trainees how to use it. I do believe in it, but to say that it's an absolute necessity, it's hard to convince some very talented older physicians who do very well without it. But that being said, I think we all have to adapt technology into our practice that makes us better at what we're doing. I still haven't seen outcomes saying if you don't use it, you're not doing a good job. So I think that's a hard statement to make.
Yeah, sure. And it's sort of some of the points that Hanain raised as well about their kind of the author's threshold when they talked about 50% being a critical stenosis. Just in terms of your practice as well, when you're using IVUS for cases, what do you tend to look for?
I'm sorry, was that for me?
Is it purely on the venography? Yeah,
sorry.
That's my to say.
You know, if you're using IVUS, I think you're going to see with IVUS the three-dimensional picture, which is the big difference that IVUS gives you over planar DSA angiography, and you're going to see the cross-sectional pancaking, which is the classic appearance that you see. I got to say, most of the patients that you have on the table, have them on the table because you have a problem with flow. So I do think, especially with IVUS, when you see that cross-sectional diameter decrease, I think 50% is the cutoff many people have given. I don't think it's educated with pressure measurements or outcomes based, but I think 50% is a number that made sense for people to say if at least half the vein is compromised, you have a significant stenosis. A pressure gradient, if you're looking at pressures of a few millimeters of mercury, will be significant in the venous system. Now, there's a lot of factors that venography doesn't account for, the hydration status, the prior history of what's going on with the patient and all that. So there's a lot of dynamic changes on DSA that IVUS can help compensate for. So for me, I think that 50% works, but more it's a visual thing, just like on DSA where many operators who don't use IVUS, they don't need the IVUS to tell them. I think it does help. I think a great person out there, Jerry O'Sullivan, is probably one of the experts that I would always refer to. You know, trusting their judgment also is good, but IVUS 50% makes sense to me. But overall, the appearance, when you see the pancaking, that's what is more of a reliable indicator.
And same question to you, Narayan, in terms of your practice.
Yeah, I mean, cross-sectional area, I think, is just one factor that IVUS is useful for, right? So when we're looking at probably the most common IVUS as a decision-making tool to decide whether you're going to treat a lesion or not. So, you know, for acute DVT, the decision's already made. They've got a thrombus. You're doing thrombectomy and treating any outflow obstruction. If they've got a descending DVT, you should really have cross-sectional imaging before they get on the table to show that they've got some venous compression. If you're treating a PTS patient, they've got occluded veins likely already. But it's where the decision-making that's solely from IVUS comes into play is when you're treating non-thrombotic iliac vein lesions. So those patients who've got just a May Thurner, but their venous system is patent. They've not had a clot or not yet had a clot, but they've got these sort of symptoms and signs of venous disease, which can be massively variable in severity and extent on patient to patient, right? And that's when you're really relying on the IVUS I heard this word the other day, the maybe Thurner to a May Thurner. You want to know whether this little bit of compression that you've seen on a cross-sectional scan is really the cause of your patient who has kind of heavy legs at the end of the day, no real skin changes, and you're deciding whether or not to offer them a stent. And for that, I don't think it's just cross-sectional area that's important. I personally put the IVUS across the May-Thurner. I ask the patient to Valsalva. I watch it move, how the vein moves as they breathe in and out. Is it a fixed compression, or is it something that just kind of opens and shuts as they breathe? And it's not just simply a question of cross-sectional area where the decision making comes from. So I find IVUS, can give you so much more than that, and the degree of compression, the degree of fixed compression tied with the patient's symptoms is what makes the decision whether to treat or not. So using 50% stenosis as a criteria, I mean, you had to pick a number somewhere. There was no good data beforehand. I mean, as you can see from the trial, we still don't have good outcome data to try to tie all of these things to. I mean, in a lot of areas of venous disease, apart from large individual center series, we don't have a lot of good outcome data, full stop. We haven't even agreed on how we measure outcome data yet. We all, if you look at all the papers for PTS in the last 5 years, there are 4 or 5 different symptom scoring systems used. So the outcome data, I think, will come, but at the moment we don't even have that. So yeah, using IVUS, I think, is not just a matter of cross-sectional area. It's dynamic venous changes. As Kumar said, it's the venogram as well. It's the flow, and it's the patient's clinical symptoms that all tied together have you make the decision on the table about whether you're going to go ahead and treat or not.
Okay,
great point.
Thanks. And just one point actually was you were talking about, Ryan, was the fact that, talking about non-occlusive iliac vein lesions and thrombotic lesions, because in this paper they seem to have a mixture of nivels and full occlusions. And it's just sort of in terms of the data from this trial, do you think that the fact it's quite a heterogeneous group of people, can you draw conclusions about when IVUS is going to be more useful in that? I mean, I know you say in your practice, obviously it's good for nivels, but do you think from this paper we can still say it has benefits in occlusive venous disease as well?
Yeah, I mean, that's the other thing that wasn't quite clear about what the exact characteristics of the lesions they were treating were, because if somebody has a long segment chronic venous occlusion, if they need treatment, you're going to stent the whole thing regardless of IVUS or venography anyway. That's where the role of IVUS becomes different, where the role of IVUS is to confirm that you've crossed in the right plane, to mark where the vein, where the healthy to healthy vessel is, to be able to stent with that perfect accuracy that I think also is difficult to do with venography alone. Kumar made a great point. There are many people who are very, very good at doing deep venous work with venography alone, but that's experience built up over decades.
Right.
We are very much standing on the shoulders of giants here. So some of the names on this paper, they've been doing this for a long time when IVUS was just a glimmer in somebody's eye at Volcano, and they get great results. But I said you can't. I suppose you could say that IVUS democratizes it a little bit, right, and makes those years of experience of landing stents precisely just so on the basis of planar venography. It just makes it a little bit easier for everyone who maybe doesn't have that experience. And I guess that's what modern medicine is all about, right? That to make sure that physician A can do the same procedure as physician B with a reasonable level of training and get the same outcome. And that's what technology in modern medicine is all about.
I gotta agree with Ryan on many of his points. I think the IVUS is an equalizer for experience and maybe understanding of what venography is or patients. I think when you're talking about occlusive disease, you're going to intervene one way or the other most likely. But I think it's a great point talking about the nivels and stuff where it helps you decide if it's maybe appropriate. But I still don't think that standalone is going to help you. I think deployment's tough in a lot of those situations where it's a occlusive chronic disease that you're recanting. Deployment on a dime is a little difficult even with IVUS, but that comes with experience. The IVUS does help, especially the younger ones, get a little bit more adept at how to be more precise in their procedures. But those are all very good points, and I think it does help everyone try to get on the same playing field. But at the same time, we see a stark increase in iliac stenting for maybe turners, like what's a great term. So that's a little bit concerning too. So we are seeing devices used at a higher rate which is weird because that means that we have a higher rate of May Thurners out there that we're just under treating.
Yeah, just to pick up one of the questions is from the audience. They're just in the discussion about sort of using IVUS versus not using IVUS, and they're talking about, they're just asking when if you want to land your stent accurately just using venography, how do you sort of identify where your kind of normal vessel starts sort of accurately just with venography?
So a couple things you can do is, number one, you have multiple projections, obviously, you can inject from both sides. You can have a up and over catheter, reverse curve catheter at the iliac confluence. And also there's a standard teaching of using the contralateral pedicle at L4, which Jerry O'Sullivan always talks about. So those are a couple of the ways. And I think those have been pretty well understood and accepted. The problems we still see with IVUS and without some mal-deployment. So some of that may be due to how constrictive that the underlying disease is. If the patient is truly a occlusion or a severely stenotic patient, that these stents are not still perfect at landing no matter how good you are. So we still see some overshooting on the deployments. But if you're using venography alone, you can do bilateral injections. You see where the confluence is. You can have an up and over target as a reverse curve just to kind of help you land it better if you need that. But again, having IVUS really does help.
And just Narayan, if you, I know, having worked, you can sometimes use a trick with we can probably explain more about it, but using a sort of low pressure balloon. Is that something you use, and anything else you use?
Oh yeah, so I mean that's poor man's IVUS, right? So that's if you're trying to decide whether a lesion is significant, you've done a venogram, you've done an IVUS, you're still not quite sure, just pulling a 40 millimeter balloon inflated at low pressure across the stenosis and seeing if the balloon wastes or not is another sort of thing that you can try. But these are all pieces of evidence that you add together and decide whether or not to go ahead and stent or not. I think definitely for landing stents precisely without IVUS, I think the reverse curve catheter over the iliac confluence is definitely the sort of my preferred method if you didn't have IVUS in the early days when we didn't have IVUS, or maybe thought twice about opening it for every case. Just getting a SOS Omni catheter or something over the bifurcation, pulling it down, seeing where it starts to splay, and then doing a run there. These modern venous stents are definitely a significant improvement on the wall stent, which does take some of the guesswork out of it. But as Kumar said, there is still, no matter how good you are, what happens, I think, when you first deploy the stent, that everything seems to change position. So the stent that you started deploying looking like this suddenly goes like that, and you just have to kind of pick your spot based on the skeleton behind and commit, and trust that your imaging before the stent deployment was correct, and then commit, deploy your stent, and then check it afterwards with IVUS or venography to make sure that you've completely covered the lesion, because there's nothing worse than half stenting a May Thurner and then they come back and you see the top end of the stent just pinched like this, not quite all the way through, and it's just such an avoidable complication.
Yeah, and just coming back to stents, because in the paper they seem to use the sort of quite main stent they use diameter-wise, it's the sort of 16 millimeter ones. Just in sort of our practice, that now seems quite large, and sort of most very rarely go above 14 millimeters. Do you think that reflects maybe just sort of a more earlier experience in using IVUS and potentially oversizing stents, and does that sort of correlate with your current practice now? Question for Dr. Madaseri, probably.
I think I guess we have bigger patients in America. I'm just kidding, but I think 14 to 16 is on average what we consider appropriate for most of our patients with common iliac May Thurner or stenosis. So I don't know if that's too small or what. Narayan, it'd be great to hear what your experience is out there. But on average, we tend to see people undersizing quite often because of what product they have available, not using IVUS. I think from most of the cadaveric studies and what we understand, 16 is about a target for most average size patients for us. Again, I don't know if there's a geographical variation, but we'd be interested to hear what you guys are experiencing.
I think we pretty much put exclusively or almost exclusively 14 millimeter stents for pretty much everyone. The odd patient, if the vein does look really big, we might go up to a 16. We found that the patients that you put a 16 millimeter in a very tight lesion seem to have more back pain for longer afterwards. I don't know if that's again just a feeling. I don't have any data to back that up whatsoever, but we just got a feeling that the 16 millimeter stents.
Well, all right. Why do you need IVUS then if you're giving everybody 14?
That's a good question, because I guess we don't do many nivels here. I'll be honest. For the last 3 or 4 years, I can probably count on maybe 2 hands the number of nivels we've done, and that's with 4 high volume operators. You know, that's sort of, if you're recanalizing a chronic, then the inflow vessel is never going to be bigger than 14, right? If you're coming, the common femoral vein is pretty much never going to be bigger than 14. So yeah, we pretty much we stick to 14, find it's the right size.
I think if you're talking about nivels versus, you know, the disease, then yeah, smaller may be more appropriate because they're going to have such hard time getting to that 16. But in the non-occlusive, non-stenotic, or the non-occlusive patients, that's when we tend to go a little bit bigger. But yeah, that's a good point.
It'd be interesting to see that with those stent migrations recently, just to see a few things about how the stents were sized, both in terms of length as well as diameter.
There's a lot of conjecture as to what makes me think why there were so many issues. A lot of people doing this, a lot of people using it, and I wonder if undersizing is an issue there.
For sure. Hopefully that'll all come to light in the next few months, because I want my I want my venous stents back.
Exactly.
Cool, very good. And just coming back to some more points in the paper, I think one of the things Hanane touched on was about the methods the authors used to sort of draw their comparative things, where they used their sort of biplanar measurements, but then that was sort of the cross-sectional area was derived from a sort of mathematical formula afterwards. I mean, obviously, as an operator, you don't have that mathematical formula available when you're doing your procedures. So, how do you find that in terms of method they've used, and do you think that calls into question any of the results they've used comparatively? Get the Ryan first.
Sorry. Yeah. So the thing is, when you have a trial like this and it's published and it's a big trial, everyone sees it, a lot of that methodology gets carried forward to the next trial, right? So I'm still filling out for like patients in clear DVT or in the pivotal trials for some of the venous stents over the last few years. You see that same kind of cross-sectional area, maximum, minimum, percentage stenosis. And it's not really applicable for all patients. So yeah, I think they did in this trial, they did slightly kind of just come up with a protocol in their heads. But again, as I said, the trial had to be done. Something had to be done to show the utility of IVUS in these patients, and they kind of had to write the rules themselves. So I may not fully agree with how they've done their measurements and done the calculations, but they had to choose something to do to set some rules for the trial. I mean, you know, they got it call lab adjudicated, but then again, it's very difficult, I would say, this is always an issue. Looking at someone else's IVUS images is not so easy, right? It's a live tool looking at it in your own hand. So I do slightly not call into question the value of core lab adjudication of IVUS images, but I do think you miss out a lot not being there in the room watching the IVUS images go through, and that was another issue, another potential issue with this paper and the way that they've measured. I mean, the other thing is when they've used the Bland-Altman plots as a statistical test to look between at the agreement between IVUS and venography. I mean, Bland-Altman's really technically are looking for agreement between 2 tests, and then if you're defining one as the gold standard, again, that brings a degree of arbitrariness into it, because we didn't know at that stage what the gold standard was, and in fact now we know as Kumar was saying, that the two methods are absolutely complementary to each other, that you get different information from each modality. So calling one a gold standard and using the other as a reference against it, I'm not sure was the correct statistical methodology. And maybe the only true way to measure that would be longer term clinical outcomes, and say patients who had IVUS leads to better decision making in the case, which leads to a better outcome outside the case. And maybe that's the only true outcome measure that we can use here.
Yeah, it's kind of interesting you touched on the point about the sort of bland outcome plots, because the authors kind of make the conclusion, as you said, that sort of IVUS is more sensitive than venography. I know Chris Hammond, unfortunately, can't be here, but he's going to sort of touch on a bit more of the potentially what it's just saying there's discordance between the two modalities. And you're not saying one's necessarily more sensitive or accurate, they just don't necessarily always agree, and you have different reasons for using them. Is that sort of what your conclusions are as well?
Yeah, I mean, you know, what's interesting about this, I think a radiologist with a ruler and a statistician with data are probably the two most dangerous things in the world. I think it's hard to come up with a way to truly measure venography on DSA. I don't think it's an exact science no matter what you do. I think we have to all accept, and I think Ryan will probably tell you that measuring on venography is more of an eyeball test than anything else. Yeah, you can measure, but just remember, especially for trainees, you got to make sure your equipment's calibrated every time you do that. You might be off sometimes. The venous system is very dynamic and volatile. You know, I use IVUS a lot in my arterial cases. That's the majority of my practice, and I think that you have a little bit more of a static vessel. That gives you a lot more reliability on the venous system. I think you have to combine DSA plus IVUS and the measurement system that they use. They have to come up with something, like Ryan was saying. I don't think they could come up with anything that's going to be concrete and everyone says, absolutely, I agree with the way they measured this. So they have to do something, but it's not apples to apples comparison saying, well, this venography system versus this venography system is the equal playing field. It's not the same thing.
It's interesting you use a lot more IVUS for arterial work. I've been using more IVUS for arterial work in the last year as well, and it's really changed my practice a lot. And there's good data coming out now that we consistently undersize, particularly tibial vessel sizes just off angiography, even experienced operators. And when you're using technologies like TCBs and you don't have vessel wall apposition, I mean, it's just, you know, floating a balloon in the air.
I think most of my patients are critical limb, so especially in the tibial, sizing has changed, but I think we're using a lot more different types of tools in the arterial system, atherectomy, laser, wave, all these other things. And a lot of times the complications you run into have far more bigger consequences in the arterial system. So having more data and information in the arterial side when there's so many varying parameters, not to say venous system does not have all these potential risks, but it's a lot more forgiving as long as you're not doing something egregious. But in the arterial system, if you're not careful with everything that's going on, I think it's a lot riskier. So, I'm not trying to change subject, but just that's why I use it more consistently there. But in these cases I'd say in a NIVL patient, IVUS is paramount, I would say, because to really want to make sure you're seeing what you should see. In a stenotic occlusive patient, you're trying to get luminal gain to get flow through that stent and keep it open. And it's going to come back. One thing I hope trainees understand is if you have a patient with likely May Thurners and you stent them, don't think you're done. As long as you're following your patients and you have a clinic, you're going to see them again, and you should be. And you're probably going to have an issue with that at some point, no matter what you do. So I think IVUS has a great role, especially in younger patients. We see these younger patients that they're questioning these symptoms and POTS disease related to venous stenosis and all that. So I think IVUS is a very critical tool in those situations, particularly.
Yeah, it's sort of interesting you mentioned about using IVUS in the arterial system, and I guess it's a question for departments that don't have sort of access to IVUS yet. So obviously we know it's quite an expensive tool, and in the UK, sort of cost is everything really in what we do. But how do you, from a sort of, it'd be interesting to hear just from both the UK perspective and a USA's perspective, how do you sort of justify the cost of IVUS for a case, both the kind of fixed costs in the IVUS machine, but also in the IVUS catheters? And for some of those people in the audience who don't know too much about the costs, just would be good to explain a little bit about that as well. Is it right to start with Dr. Madasseri for that, please?
Sure. I mean, cost is obviously a factor, and you have to keep that in mind. Now, people will say, "Well, here, no one really cares. No one's really paying attention." But that's not true. A lot of people are operating in their own office-based labs now, which is called an OBL, and that's basically where they go set up their own clinic in their own place, and they do procedures because reimbursement, you get to pocket more of that if you do a good job, and that's what we hope people are. But every single thing you pay for comes out of your profit. So it's not cheap for those people. Now in the academic setting, yeah, I can use it left and right, but you have to lobby for what you think is best for your patient outcomes. And if you think it's necessary, you have to lobby for that. Now, also you can talk to industry and your reps and see, is there a way to work something out? I can't speak for in a national system how to navigate those minefields, because I'm sure it's very different. But trying to use the data that's out there, there's no great randomized data, but I think getting expert opinions, using whatever prospective, retrospective, meta-analysis that you can find is the only way. But at the end of the day, for me, there's many people doing procedures that should probably use IVUS without it. I'm not saying they're bad, but if you take a proportion of people and ask how to do better, it's going to be with using the right tools. So for us out here, if you're doing the right thing, you're doing a good job, you need to spend that extra money, whatever it takes, and lobby for it. It's not going to happen everywhere. It's not a perfect system.
Yeah, reimbursement for IVUS is an issue in several countries, isn't it? I think there's a couple of parallel tracks happening. The first is that I think the cost of the technology will slowly come down over time. It has to, and I'm sure the companies will be trying to squeeze it a little bit as time goes by. But then the next thing is outcome data, right? So there's as more and more outcome data gets published for venous work particularly, and we can show that, okay, these are the results you get, but these are the tools that are used, then that's the way that we're going to be able to justify the cost of it. I mean, I think we have to, I hate to say it, but I think we have to look over to the cardiology cath labs as well and see how they've managed to work it into their billing, because I don't know many cardiologists here who would put a patient on table without having two forms of imaging, one being fluoroscopy and one being either OCT or IVUS, some form of intravascular cross-sectional imaging. So they have clearly managed to work it into their billing setup that they can get paid for it. So we have to find a way to do the same in ours.
I think I was just going to a question. I think about the topic of industry, because I find that's very interesting. There's you get a lot of support from industry, and you need the support of industry to get some of these tools into the lab and try to get new devices. But where do we draw the line? Where do we decide right, this is actually a conflict of interest that's harmful to developing new things. You're very biased, but at the same time you can't do it without them. How do you find that balance? As trainees, that's something you don't experience until you become a consultant, and that's at that point, what do you do? How do you know how to deal with it? I think it'd be interesting to hear both the UK and the US perspective.
Do you want to take that one first?
I don't know why you want me to take it. That's fine. No, I think that's a very valid and very important question, especially as trainees. You have to learn how to navigate this field. If that's something in your environment, I'm not sure what it's like there, but for us here, it's something we try to guide our trainees a little bit into how to work with industry in an effective manner to deliver better patient care. I know it sounds like a great altruistic statement, but you can. It's going to be hard to find registries, early studies, prospective studies that doesn't have people involved with the industry, myself included, because we're the ones who tend to use a lot of it, and they need high volume and a fast turnaround. Now, can you trust it? You have to take that with a grain of salt when you review a paper, which is what you guys are doing here. If the data says all flowers and beautiful smells, that everything is perfect, this is great, obviously you want to question it, but data is data. If you can evaluate and say the study was done very soundly, this isn't a NIH-funded double randomized controlled trial. This is basically a prospective evaluation or retrospective evaluation. So you have to take every single one of those with a grain of salt. The conflict of interest is somebody everybody has to disclose, and hopefully they're doing that with the best intent. But you're not going to avoid physicians who work with industry in these type of reviews and studies, because they're the ones who are doing the volume. You can hope and you can search, and I think people know who are the ones that you should be able to trust, and you have to develop a good academic sense to evaluate what the numbers and the data that's coming out.
Absolutely.
Yeah, I think a lot of it is, as Kumar said, when an industry partner has spent millions of pounds bringing a device to the point where you can actually get it to the stage where you can put it in a patient, they need somebody who's going to do a lot of procedures to validate that very quickly, and that's how partnerships with clinicians come about. I think when you guys are consultants, attendings, when you guys are in those positions where you're being approached by people, I think the key thing is I always want to be able to use the best available kit out there for my patients and the latest stuff. If it works, I want to try it, and if it works, I want to use it in people. I want to get it into patients' bodies as quickly as possible, and that needs some degree of engagement with industry. But I think the key is that the moment anybody from industry asks you to do something that just twitches a nerve inside of you, that you're kind of, I'm not sure I'm really comfortable with that, say no. That's fine. You don't have to assume that working with a company for 5 years on something that you agreed with them with and you thought was a great technology, and then they come to you and maybe try and twist your arm to do something else that you don't quite believe in. You can say no. What you did before doesn't mean that you have to agree to promote something or to try something new, a new product or whatever that you don't particularly agree with. So I think a lot of it is just staying true to yourself in that sense, and realize that we're all here for the patients at the end of the day, right? That's the reason for all this industry engagement, is we want to get new stuff that does better work into patients.
Yeah, I think that, I mean, it's about just knowing your moral compass and just knowing, you know, when you sort of draw on the line, and, you know, you just need to navigate yourself. And it's just, I think that's kind of culture we need to be brought up in, you know, as we're being trained. You know, thanks very much for that. We just had a few questions from the audience. I think Rosemary has been very helpful collecting some of them. So I think we'll just sort of quick fire through some of the questions that have been asked. And I think what we'll do, we'll just take in turns, just some of the questions that some people have been asking. I think some people have messaged us directly, so I'll pass it on to Rosemary, who's got collected them.
Hi everyone, I'm Rosemary. I'm one of the medical student representatives for the British Society of Interventional Radiology's Trainees Committee. So the first question is, what are some complications of using IVUS in the venous system? And maybe we can direct this firstly to Dr. Narayanan.
Complications from using IVUS. Not sure there are really any from the device itself. As long as it's going over a guide wire, you're probably going to be fine. I think the complications come from misreading the images more than anything else, rather than actual use of the device. So I think I'll tie that to something specific. On a venogram, you kind of have this, you have the skeleton as a marker of where you are in the body. On IVUS, the only way that you know where you are somewhere is by correlating that with fluoroscopy or seeing branches coming off the main vessel that you've got your IVUS catheter in. So it's not, I don't know if it's necessarily a complication or just a misdiagnosis. If you should always, whenever you do an IVUS pullback, put the IVUS catheter in a place where you absolutely know where it is when you start your pullback, and then count the vessel branches on the way down, so that you know when you get to the bottom, you know where you are. So that in the most simple circumstance, that would mean, say you've punctured the femoral vein in the thigh, you've crossed a Maytherner, get the IVUS all the way up maybe to the right atrium, and you can see that it's the right atrium, and then start your pullback from there, so that you can measure, you can see where the renal veins are, you can see then where the Maytherner lesion is, if that's what you're looking for. So I think just using landmarks and knowing where you start and finish is probably the most basic thing that I would say, to avoid any misrecognition of where you are on IVUS images.
It's really helpful.
Thank you for that. And I guess sort of on a similar point, Dr. Kumar,
Yep.
Does using IVUS increase the procedure time significantly?
It does increase procedure time. It increases cost. I don't think it's significant if you're comfortable using the product. I mean, usually for most of us, I'm sure for Dr. Narayan as well, is it adds maybe 5 minutes at most if you're comfortable using it. So that's not significant to me. If you're early operator, if you're not sure what you're doing, if your staff in your room doesn't know what they're doing, yes, it adds time, but it's not considered at all. I don't consider it as all as a waste of time. It's just a cost issue and comfort level type thing, but not a time problem.
Can I ask you a question? Do you control the IVUS completely yourself? Like, do you do all the button pressing on the screen? You don't.
No. But here's the thing, though, and this is important for trainees. Any product in your space, you better be the expert, because the people that are in your room that are helping you, if that's what you guys have, they will always have problems. There's turnover. They don't understand. They're not paying attention to the level of degree that you are in general. So I don't control it, but I have my tech across from me who's doing the buttons for me. And I need to know how they're not getting something right. I need to know how to fix that. I need to know what they're doing wrong. So I do have somebody else do it. I have a tech, but we have several techs. We have 9 rooms, so not all of them are as apt as it. There's a super user, but that person may be off. So I have someone else do it, but I need to know 100% how to use that product and how to troubleshoot
it. So we've got another one. So does the use of IVUS reduce radiation exposure?
Absolutely. And don't forget, venous patients, a large cohort of them are young females, where you're going to be screening over all the gynae bits, for want of a better term. So, using IVUS is, for me, I probably don't use venography maybe as much as I should, but for these kind of patients, I might just do a little squirt of contrast at the beginning. Say for a PTS patient, I might do a little DSA at the beginning just to identify where the microchannels are we're gonna try and recanalize through. Then we'll cross with fluoroscopy, check with IVUS, deploy the stents with IVUS, post-dilate, check landing zones, etc., etc. And then once I'm happy that everything is good on the IVUS, only then will I spend the extra radiation to do the final DSA just to check flow. So I think if IVUS is used well, it can definitely reduce radiation exposure in the venous system, and in the arterial system, I find it reduces my contrast dose as well. In diabetic CLI patients, using IVUS saves contrast as well. So it might add a little bit of time, but there are definitely savings on radiation and contrast if it's in an applicable patient population.
And do you think there's any role for IVUS in dialysis or AVF, or is there just no cost benefit to that?
In dialysis or AVF, I don't know if that means relates to endo AVF, but in dialysis intervention, we do a good chunk of dialysis intervention every day. I don't see a particular value in dialysis circuit evaluation. Maybe in a central situation, central occlusion, you want to make sure you're in a venous, you're in the right channel when you do a central recan. That might have some value, but in a regular dialysis circuit, I can't find a very good value cost benefit. These patients are coming back frequently. The benefit of using it versus the cost of time, I don't think there's a benefit. There's a personal opinion.
And what about the UK perspective?
Yeah, I don't think in routine management of dialysis AV fistulas, I don't think it has a role. I have started using it for central vein recanalizations in patients with line-associated central vein occlusions, just because it's nice for vessel sizing, especially when you're doing sort of kissing stents into an SVC. It's nice to look for healthy sort of landing zones out in the brachiocephalic or even subclavian veins. So it's nice for that stuff, but for just dialysis fistula access maintenance, no. For that, you're just looking for flow, right? If there's going to be a problem, it's going to be a big stenosis or a big chunk of thrombus, and if you don't see that and you see flow, you're going to be all right.
Yeah, so I think that's it from the. I think we've got a few more questions from the audience, but I think if we'll be here all evening if we keep answering the questions. But I just want to say that thank you so much, Dr. Madashri and Dr. Noran, for your time and talking through the subject. I think it's really interesting because I think IVUS depending on where in the UK, depending on where you go, it's difficult to get access to it, especially as a trainee. And it's more of a senior trainee that you kind of get used to it. And it's not something you get taught as a formal modality. You don't get assessed on. You get assessed to death on like chest X-rays and abdominal X-rays and angiographics. IVUS is a modality I learned for the first time from a cardiologist. So I mean, it's great to know stuff like this, and going through this journal club, I think that was one of our intentions. It's just an area that's understudied and underappreciated, especially by radiology trainees. And so it's just great to have this. I thought a venous approach is a lot different to arterial. I think it's something where literature is not quite there, and that's what I found when studying the literature with this. But yeah, no, again, thanks so much. I mean, if there's any other thoughts that either yourself, Dr. Madasri, Ben, or Dr. Ryan have.
I will say thanks so much for this, but I will say just one thing for trainees, focus also on getting a mentor and focusing on the regular fluoroscopic procedures, imaging approaches, because at the end of the day, you are the single expert in fluoroscopic guided procedures. No one else should trump you in that. Having these expensive extra tools to make you better at it, that's absolutely fine. But still be the best at, in fluoroscopic, ultrasound guided procedures more than anybody else, because every other specialty is tackling on to any of those. Whoever there's money, they're coming in. Just like, you had to learn IVUS from your cardiology colleagues. That's fine, but don't learn anything else from there. You master every single thing in the interventional space. And I think that should be the focus for all trainees.
Absolutely. And don't forget, IVUS is ultrasound, right? So if it's an ultrasound picture at the end of the day, you can learn, there are a few nuances to learn, but it is just an ultrasound picture, just looking around you from inside a vessel. I mean, we did a case the other day of just a liver biopsy from the femoral, from the IVC, using IVUS to guide where to go and do that. It's just ultrasound. So as long as you remember that it's just ultrasound from a different viewpoint, you'll be fine.
Great. So I think that sort of brings us to a close. So no, thank you very much for participating. I think we've got quite a few participants. I think there's lots of people on YouTube as well. So this is being live streamed on YouTube. So thank you for everyone who's on YouTube as well. I think apart from that, there's we want to do more of these sessions. I think people find these are really great, especially for IR trainees here. I think the pandemic's done a few things, but one of the few things that's done well is I think webinars, and having sessions like these has been great, especially for our learning. So we've got a feedback form if anyone's interested. Anyone wants another topic, anyone wants to give any feedback to the speakers, especially if you found it really particularly useful. We put a sort of feedback form in the chat, but other than that, thank you so much for all being here, and leave you to the rest of the evenings if you're in the UK, or leave you to the rest of the afternoons and taking your time in the afternoon in the US. Or
it's only midday break. It's only midday break for us.
Yeah, you're going back to the lab then, I guess.
Yeah, in between cases.
Thank you very much for your time.
Thanks, everybody.
Thank you, guys.
Thank you.
Thanks. Bye. Bye, everybody.
Thanks.